Good morning and welcome to Grand Rounds. My name is Deepan Shah. I'm the head of cardiac imaging here at Houston Methodist. And with me here in the studio is Dr. Mike Reardon, who's a cardiovascular surgeon that needs no introduction. And we're very glad to have with us Dr. Marc Dweck as our guest speaker today. Before we introduce Dr. Dweck, just a couple of housekeeping announcements. We're broadcasting live via live stream and YouTube. This recording will be available for viewing. Please also consider subscribing to the YouTube channel to get notifications when new videos are added. For our viewers that are tuning in, if you have questions, please text DeBakey to the number 37607 and enter your question, or via the web, you can go to pollev.com, enter the keyword DeBakey, and type in your question. We have one remaining conference that I want to mention this year, which is the Pumps and Pipes Conference, which will be held on December 5th. Now let me get right to our speaker today. So Dr. Marc Dweck is the chair of clinical cardiology and a British Heart Foundation Senior Clinical Research Fellow. He's a consultant cardiologist at the University of Edinburgh and the Edinburgh Heart Center. His research program is really centered around multimodality imaging. And he's one of those few individuals that's really well versed in echocardiography, cardiac CT, cardiac MRI, as well as cardiac PET. And his goals are really to try to improve our understanding of cardiovascular pathophysiology with the ultimate goal to improve patient assessment, patient care, and patient outcomes. Marc really is no stranger to cardiac imaging. He's a board member of the European Association of Cardiovascular Imaging. He's the chair of the EACVI accreditation for cardiac CT, and he serves on the editorial board for Heart, European Heart Journal CV Imaging, Circulation CV Imaging, as well as the Journal of Nuclear Cardiology and Circulation. I could go on and on and on about Marc, but I think what I really want to do is to give us a chance to hear Marc talk to us about emerging assessment options for patients with aortic stenosis. So Marc, I want to go ahead and turn it over to you, and then hopefully we'll have some time for questions at the end.
Okay, so Deepan, thank you very much. Thank you for the nice introduction. Thank you to you and to Mike for the introduction. It's great to be here, and I'm looking forward to the next hour or so. I'll not speak for all that length of time. Hopefully we'll have time for questions and discussions at the end. But basically the talk is around new ways of imaging patients with aortic stenosis and how potentially these might help the care that we provide to patients and maybe accelerate the development of new treatments. So we are lucky, I think, to live in an era of multimodality imaging. We have all these different scanners that we now have at our disposal that we can use to image the heart, image the cardiovascular system. And using them, we can get really, I think, amazing and beautiful pictures of the heart that can tell us about the structure of the heart, the anatomy. This is a cardiac CT. You can get this scan acquired in just a couple of seconds. You can look at cardiac function, the structure of the myocardium, how it moves. This is a cardiac MRI scan. And we can even, with molecular imaging techniques, and we're going to talk about a bit about this today, PET CT, PET MRI, get assessments of disease activity. As the disease processes are occurring in the body, in the heart, we can measure them using these PET scanners. So really the information that we can gather from the heart now is spectacular. And the challenge, I think, that faces imagers doing research is how do we translate these beautiful pictures and this important information, we think, actually into concrete improvements in our understanding of the pathophysiology of heart valve disease and other forms of heart disease, but I guess most crucially into improved patient care and outcomes. And that's what we're going to try and explore in the next, 40 minutes or so. I guess the other thing just to talk about quickly is this concept of multimodality imaging. And I think, people ask me, what does that mean? What is it? And I don't think it's getting all these tests in one patient and wasting a bunch of resources and time. I think it's really about understanding what each of these different imaging modalities can offer us, and then picking the right one, the best imaging technique that we have available to answer our research question or indeed our clinical question, and actually being efficient with how we use these imaging techniques. So the talk today is going to focus very much on aortic stenosis, and at least for the purpose of this talk, I've kind of split it up into three parts. So the first bit is going to focus on the stuff that we think of immediately with aortic stenosis, and that's the valve, the stenotic valve that really characterizes and defines this condition. But also, of course, when we thinking about particularly the latter stages of the disease and the development of symptoms, adverse events, and when we should operate on the valve, we also have to consider the effects of the valve on the myocardium and how the heart muscle is coping in the face of the increased afterload that is imposed upon it. And then finally, I want to consider, what happens after valve replacement. How do we assess patients who have often bioprosthetic valves, look for degeneration, endocarditis, etc. So we're going to cover all these three areas in the talk. So if we start with the valve, we've been trying for a long time to understand what causes aortic stenosis. And this slide kind of summarizes pretty well our current understanding. And of course, there are similarities that you can see immediately with atherosclerosis. So particularly in the early stages, we get endothelial damage, we get lipid infiltration, we get inflammatory cells invading into the valve. And then afterwards, we get this transition to the phase of the disease that's more characterized by progressive fibrosis and then calcification in the valve. And those two processes are driven by myofibroblasts, i.e. activated fibroblasts in the valve. And then these further differentiate to an osteoblast type phenotype. So the cells that create bone we can find in the valves. And indeed, you can often see evidence of bone formation within these valves. So that's our current understanding, but it is a bit limited. And as a consequence, we don't have any effective medical therapies that can slow aortic stenosis progression. It's maybe the last major cardiovascular disease where we don't have a drug treatment that we can give our patients. And we have to rely on valve replacement when the valve becomes severely narrowed. And, in part that reflects our incomplete understanding of the underlying pathology. And that in turn is because we don't have any good animal models of aortic stenosis. And so really this is where imaging, I think, comes in, this ability to study the disease in humans as it is occurring, work out which of the processes are really driving the condition, and then potentially, target those with new therapies to develop a drug treatment for AS. So one thing that we do know is that calcification is important. I mean, people refer to calcific aortic stenosis. It's a defining part of the condition, and very early studies, these are nearly 20 years old or over 20 years old, looked to quantify how much calcium there was in the valve, and they used echo because that's what we usually use to assess aortic stenosis. And this very kind of crude categorization of how much calcium do you have in your valve, and graded 1 to 4. And even with this very kind of crude and initial assessment, the more calcium you have, the faster disease progression is. And this provides powerful prediction of how quickly you're going to need a valve replacement or die. So we understood for a long time that just quantifying calcium is potentially an important thing to do in patients who have aortic stenosis. And a different technique to what we usually use in aortic stenosis to grade severity, where we're relying on the hemodynamics of the valve. This approach is different. It's looking at the structure and the anatomy of the valve to define severity. But if you want to quantify calcification in the cardiovascular system or elsewhere in the body, then really CT is the best way, the best imaging technique that we have of doing that. And we can apply the same technology, the same scans, the same image analysis equipment to quantify calcification in the valve as we have been doing for a long time in the coronary. So we can just move all the stuff we've been doing for coronary CT calcium scoring, apply that to the valve, and get an assessment of the burden of calcium in the valve. And it turns out this is a pretty good anatomic assessment of aortic stenosis severity. And it's particularly good once you realize that men and women need different thresholds, different amounts of calcium to cause severe aortic stenosis. And when you apply sex-specific thresholds, so about 1,300 for women and about 2,000 for men. And if you do that, then we seem to have an alternative assessment of aortic stenosis severity. The initial studies were done at the Mayo Clinic largely, and before they got rolled out to be used across the world, we were interested in seeing whether we could use this technique in a sort of more real world setting. So we set up a study where we got centers from North America, from Europe. We took a pragmatic approach where we asked the centers to do the image analysis. CT calcium scoring was done on a whole range of different scanners using different softwares. And we wanted to know, are these thresholds actually reliable in everyday practice? And what was interesting is that when we looked at our cohort of nearly 1,000 patients, the thresholds that we had for severe aortic stenosis were almost exactly the same as had been proposed by the initial study from the Mayo Clinic. So again, about 2,000 for men. You can see how similar those two trials were, those two thresholds were. About 2,000 in men and about 1,300 in women. And if you use that and you compare it to echo assessments that we're confident are accurate in defining severe or non-severe disease, then you get an area under the curve of about 90%. So pretty good. I mean, for any imaging technique, an area under the curve of around 0.9 is really quite impressive. So, 0.9 of the time you're getting the diagnosis correct. And the other thing is that when you look at the prognostic power of CT calcium scoring, it's powerful. It has a close relationship to your disease progression. So what happens to your change in calcium score over time? And then that translates into powerful prediction of when people are going to need a valve replacement. And when we looked in our study, it was the most powerful predictor of valve replacement in the study, and it outperformed even the echo. So that was actually a surprise to me, because we're using the echo to make the decisions about when people need a valve replacement. And despite using the echo in that study and not using the calcium score was a better predictor of the need for valve replacement. So it's good diagnostically, it offers predictive value. It's a useful technique when tested in a big international multi-center study. And so on the back of that, then, and other studies, the calcium scoring has now been included in international guidelines, both the European and American guidelines for the assessment of aortic stenosis, and in particular in patients where we're not sure from the echo if it's severe or not. So that's quite a lot of patients. In some estimates, it's around a quarter of the patients that we see. We're not entirely clear whether they have severe or non-severe disease. They have discordant hemodynamic assessments, most commonly where the Vmax suggests it's moderate, but the AVA suggests it's severe. And how do we know what to do in that situation? What do we believe? Do we believe the AVA or do we believe the Vmax? Well, you can turn to calcium scoring to clarify that situation. And certainly that's having now incorporated CT calcium scoring into our TAVI protocols. That's really sped up our TAVI meetings, because we don't have long discussions anymore about, is it moderate, is it severe? In the discordant patients, we turn pretty quickly to the calcium score and we make decisions and we kind of move on. So I guess that's the first iteration of the anatomic approach to aortic stenosis severity. But of course, calcium scoring, having told you how wonderful it is, has a limitation. And the main limitation is that it only quantifies calcium in the valve. And that's important in a lot of patients, but it completely ignores another important feature, which is the fibrosis, the fibrotic thickening that also contributes to aortic stenosis. And fibrosis is a particularly important part of the condition in women, in patients that are younger with bicuspid valves. And so in those patients, either use a lower threshold for the calcium score has been suggested, but you need to be cautious because you are only assessing one part of the pathology. And so I think the natural progression of CT imaging and aortic stenosis will be to move to contrast CT, a bit like what we've done in the coronary arteries. We moved from calcium scoring to contrast CT. And using contrast CT, we can see both the calcific thickening and we can see the non-calcific thickening. We can set thresholds that quantify those things. And we can give a total burden of disease, a fibrocalcific score, if you like, to tell us what's the anatomic severity of aortic stenosis. And there's been initial studies from our group that have looked at that. This first approach was a bit cumbersome. It took about an hour to do the image analysis. But now we've got a technique in collaboration with a group at Cedars-Sinai. We can do this image analysis in about 4 or 5 minutes. And it's semi-automated, it's reproducible. And I think, in 5-10 years, this is what we'll be using. And the beauty of this is you can also use it on the CT TAVI scans that we do in routine practice before patients get a TAVR procedure. This is just some data showing that the reproducibility of the fibrocalcific score is very good. This is the noise you can see in the red lines. This is the noise in the measurement that we get. And if we compare that to how much the fibrocalcific progresses over a year, you can see that we have a technique that's pretty good at detecting disease progression and also potentially for looking at whether novel therapies are working, whether they're reducing the fibrocalcific burden in the valve. And these are some group estimates. If you're thinking about doing a trial with a new drug, potentially the fibrocalcific score is useful because you don't need very many patients to detect a treatment effect of 20 or 30%, which is probably what we need for a drug to be effective. So that's CT scanning in the valve. And we're now going to move on to PET imaging. And this is really an exciting technique. I mean, of course, it's been around for a long time, and you guys do a lot of PET imaging, particularly with perfusion and viability imaging, and we do the same. But what I'm going to talk about today is different from that. It's not the routine clinical PET imaging we're doing. It's more a technique where we're looking using the PET as a molecular imaging technique, and we're trying to measure disease activity in the heart and in the valves. And so the basic idea behind this is that we take a radio tracer that's targeting a specific pathological process, we inject it into the body, and we let it accumulate where that disease process is active. So here's a marker of calcification activity. You can see uptake in the bones, as you would expect, but you can also see uptake in the middle of the chest. So we don't get any spatial information from this, but if we do a CT scan with the patient lying in the same position, then we can fuse the two images and see that actually this calcification activity is coming from the aortic valve. So in principle, we can look at any disease process that we want if we have the right tracer. And I think what's particularly exciting about PET imaging is that now we have tracers for all the processes that we're interested in really in cardiovascular disease. We've got tracers for inflammation, calcification, fibrosis, thrombus formation. So I think we've got most of the processes covered, and we can now measure that in patients in real time to see how active these processes are. So what does PET add? Well, for the purpose of this talk, it's about disease activity. And so when we apply this technique to aortic stenosis, and in particular with a tracer that targets calcification activity, we can start to work out where in the valve the calcification activity is coming from. And you can localize it to individual leaflets. Here you can see uptake in a very common pattern, which is really at the tips of the leaflets where they're banging into each other. It's perhaps no surprise that mechanical stress is high in those areas, and therefore so is calcification activity. We did an initial study. This is quite a while ago now. This was my PhD over 10 years ago that we started it, and we were interested to know whether what was the more important process in aortic stenosis. Was it calcification or was it inflammation? We'd spent a lot of time with statins doing trials to try and target the inflammation, but actually what was the relative contribution of these two processes to aortic stenosis? And we looked at 120 patients. They had a full spectrum of disease severity. And what we found was interesting. Inflammation was increased in aortic stenosis versus controls, but not actually by very much. It was quite a small increase in the signal. But by contrast, the calcification activity was really very much increased in these valves, particularly in patients with moderate and severe disease, where really the calcification activity far exceeded any inflammation activity. And I think this convinced us that, if you're going to develop a treatment for aortic stenosis, it has to have an effect on calcification. You have to target calcification in some way, perhaps not to reverse it because that's difficult, but certainly to prevent its further accumulation within the valve. And that, really calcification was the bad guy that we had to hit in developing new treatments. The other thing about the PET imaging and that study is that we then repeated scans down the line. So we were able to look at disease progression. And I think this slide probably sums up how PET works and how fluoride works as a marker of activity. So these are the baseline scans, and you can see the CT images here. The white areas are areas of big macroscopic clumps of calcium, and the red and the yellow areas are regions of fluoride uptake, our calcification tracer, and that's telling us about calcification activity. And you can see that the distribution is different. It's telling us about areas of calcification formation that we don't see on the CT. These are occurring before we see any evidence of calcium on the CT. But when we repeat the scan in 2 years, we see that the areas of new calcium on the CT have developed in much the same region that we saw the activity at baseline. And that translates, when we look at the whole cohort, to the PET, again, providing good prediction of the change in your aortic valve calcium score and also of clinical events. So it's a marker of activity that we can measure in the valve. And so as we were kind of putting all this together, thinking about, what the next steps were going to be, we came to, a few conclusions. One, as I said, we thought calcification is the bad guy in aortic stenosis. And really what we want to do is try and target the calcification to slow disease progression, to develop a new medical therapy for aortic stenosis. And we realized that we had pretty good biomarkers to assess whether the drugs might be working in the form of the PET and the CT scans. And so we designed Saltire 2. So Saltire 1 was our first attempt at developing a drug for aortic stenosis with statins, and that didn't work. But Saltire 2 was our next attempt, and we instead this time really tried to target the calcification in the valve. And we did it with two drugs that osteoporosis agents. So one of the challenges, if you knock out the calcium in the valve, you need to maintain bone health. And we thought that osteoporosis agents would give us the best ability to do that. And it was a phase 2 trial. We weren't really looking at clinical endpoints, but we were looking at what the effects of those drugs were on the hemodynamics of the valve, the change in the calcium score, but also the change in the calcification activity with the sodium fluoride PET. So this got reported last year, and it was neutral again. So I guess disappointing, but very consistently neutral. I mean, everything was neutral. The change in the aortic valve calcium score was neutral. The change in the aortic jet velocity was neutral, and the change in the calcification activity with the PET was neutral. So these drugs, denosumab and alendronate, weren't having an effect on calcification or the hemodynamics in aortic stenosis. So if you're being optimistic, you say, well, that's good. People that we're treating with osteoporosis, we're not having any impact, negative or positive in the valves. But if you're trying to develop a treatment for aortic stenosis, it was a little bit disappointing. Having said that, I think this trial established the model for how, in the current era of multimodality imaging, we should do phase 2 clinical trials of new drugs in aortic stenosis. And certainly it's been adopted now in lots of other studies investigating other potential therapies for AS. So this is a trial that's about to be reported from the group in the Netherlands. They again used a very similar study protocol. We helped a bit with this, where the primary endpoint was echocardiography and the CT calcium score. And then they also looked at sodium fluoride as PET as a secondary endpoint. They're looking at vitamin K as their study intervention. This is a trial being run by my good friend Marinique Clavel. She's in Quebec, and she's looking at losartan. So her primary endpoints, again, echo and CT calcium scoring. She's also looking at contrast CT and there's a PET study, PET sub-study to this trial. So this again is ongoing in Quebec, Edinburgh, and in Denmark. And then there's other targets, and one of the key targets I think that has emerged is lipoprotein(a). So this is, I mean, we've known for a while, since 2013, that the lipoprotein(a) gene is a very, very powerful predictor of incident aortic stenosis and aortic valve calcium. And there was this landmark study in the New England showing that the SNP that really was associated with aortic valve calcium beyond anything else was lipoprotein(a). And then subsequently, there's been studies that have used these imaging techniques to show that patients with higher lipoprotein(a) levels have increased calcification activity with the PET, and that translates into faster disease progression on the CT, on the echo, and a higher risk of aortic valve replacement. So lipoprotein(a) is a very attractive target because it's associated both with the incidence of aortic stenosis and crucially with disease progression. And it's especially enticing because we now have very powerful drugs that lower lipoprotein(a) levels by up to 90%. So we can really knock this out as a target. And again, here's a very exciting potential therapy for aortic stenosis, which, importantly, big pharma have taken on. And so for the first time, we've got big pharmaceutical companies really investing money and resources into developing a new treatment for aortic stenosis. I think recognizing that this is a big potential market for them. I think they've seen the success of TAVI and how much money you can make in aortic stenosis, and have bought into the idea of trying to develop a medical therapy for this condition. So that's the valve. So we're on to phase 2, which is really about the heart muscle. And I guess this is just to this slide is to remind you that we have to think about what's happening in the heart muscle as well as the valve, particularly when we get to the end stages of the disease. And we're trying to work out when is the best time to replace the aortic valve. So at the moment, the way we think about it is really around this slide on the left, where we don't want to operate too early on a valve because that is exposing the patient unnecessarily to the risks of surgery and TAVI. But also, we're not curing the disease; we're effectively swapping aortic stenosis for another form of valve disease, which is living with a prosthetic valve that is prone to its own problems: endocarditis, valve degeneration, if it's a mechanical valve, anticoagulation. So we don't want to do things too early, but equally we don't want to do things too late because of what's happening in the heart muscle, and because you can leave the patients by operating too late with irreversible damage to their heart muscle. So irreversible scarring, as we'll see, that can then govern an increased risk of heart failure, hospital admissions, and death for those patients. So we don't want to do it too early, we don't want to do it too late, but we want to do it just at the right time, which most people think is just as the heart muscle is starting to decompensate, but not leaving it too long so there's too much irreversible damage. And so for a long time, based around that, we have operated on people who have severe aortic stenosis, evidence of severe valve narrowing, but also some evidence that the left ventricle is starting to decompensate, most notably the development of symptoms. That's really the predominant way that for many decades we've been operating, using symptoms as our guide to say that the heart muscle is struggling. But of course, symptoms have a problem. And the original study by Brownwell, which is now over 50 years old, and the traditional Brownwell curve that gets shown, if you look back at that study, that was done predominantly, in patients that were dead because it was a post-mortem study, but also in younger patients. The average age, I think, of symptom development there was patients in their 50s. And it's probably quite easy to assess symptoms in a 50-year-old, but it's much more challenging to assess symptoms in the 70, 80, 90-year-olds that we see in clinical practice, where either they have lots of other comorbidities that might be making them breathless, or they have reduced mobility, which means they can't exert themselves to unmask their symptoms. So I think symptom assessment is challenging, and potentially, there's ways of developing more objective markers that the heart muscle is starting to decompensate. And as we're trying to develop those objective markers, again, I think it's important to go back to what's happening in the heart muscle. What's the pathology? And so when we have aortic valve narrowing, that increases the afterload, and that triggers a hypertrophic response where we get thickening of the heart muscle, we get increased myocyte size, and that's a good thing. That restores wall stress, it allows the heart to pump efficiently, and it keeps the patients well for many years, if not decades. But with time, that hypertrophic response can decompensate and patients transition from hypertrophy to heart failure. And the two pathological processes that cause that decompensation are scarring in the heart muscle and the death of the myocyte. So potentially these are two alternative targets where we can use to identify left ventricular decompensation as an alternative to symptoms. So if we think about the scarring and how can we potentially detect scarring in the heart muscle, then really the tool of choice, the imaging technique of choice is cardiac MRI. This is by far and away the best way of finding scarring in the heart muscle. And of course, we use it a lot in clinical practice to look at myocardial infarction and scarring and other cardiomyopathic conditions. And similar to those, we can use it in aortic stenosis to detect areas of replacement scarring in the ventricle. And you can see some examples here. So the normal healthy heart muscle looks black on these scans, and areas of scarring looks white. And you can see these patterns of scarring in patients with aortic stenosis. And crucially, we can differentiate this pattern of scarring from the type of scarring that's caused by ischemic heart disease. So this is very much specific to the aortic stenosis disease process, and indeed a marker of left ventricular decompensation. So when we look at what it means in patients with who have myocardial scarring and aortic stenosis, it's associated with multiple different other markers of left ventricular decompensation. So troponin, BNP, abnormally high LV mass, as well as markers of LV function such as ejection fraction, and then more sensitive measures like global longitudinal strain. And it's associated with patients' exercise capacity and their ability to perform the 6-minute walk test. So lots of studies now, I think, showing that this is a marker of left ventricular decompensation, as we would expect from the pathology studies. But what's, I think, interesting is these longitudinal studies that have been done in MRI by our group and by actually lots of others now, and they all tell the same story. So I think it's illustrated nicely by this patient. So this was quite a young patient who had a bicuspid valve. He was in his late 50s, and we scanned him at baseline as part of the research study. He had severe aortic stenosis, but he was asymptomatic, and he did, I think, 12 minutes on the treadmill test. I mean, he was truly asymptomatic. But when we looked at his MRI, he had a clear area of scarring in the left ventricle. You can see that with the white arrow there. So he was asymptomatic. We didn't operate, and we kept an eye on him. 6 months, he was okay. At a year, though, he had started to develop some symptoms, and he had a repeat MRI scan as part of his assessment just before he got sent for an aortic valve replacement. And you can see that the scarring that was there at baseline is still present. But crucially, he developed further areas of scarring in the heart muscle. And so these areas of scarring had occurred whilst he was asymptomatic and whilst he was waiting for his valve replacement. So he had the valve replacement, and then he came back a year after the valve replacement. And what was interesting was that the areas of scarring that he developed whilst waiting for the surgery were still there. They hadn't gone away. They hadn't reversed. They hadn't progressed either. The valve replacement had stopped them from progressing, but they hadn't reversed. And this has been shown time and time again that these areas of replacement scarring that you develop whilst you're waiting for your operation stick with you even after the operation, and you stick with you until the day you die. And is that important? Well, yeah, it is important, because that form of scarring is a very powerful predictor of your outcomes following aortic valve replacement. And that has now been shown in lots of different studies all around the world. This is data from London, from Germany, and then most recently a multi-center UK study, 700 patients. And the presence of late enhancement on your scan just before you have your valve replacement was the strongest predictor of all-cause mortality and cardiovascular mortality post AVR. So, whilst we're waiting for surgery, the patient's asymptomatic, we reassure ourselves everything's okay, but actually there's often fibrosis developing in the background, and that's governing these patients' long-term outcomes. We can do it. We can use another MRI technique called T1 mapping to do a similar thing, but this time in a more quantitative way. And when you look at that, it shows the same thing, that the fibrosis is a very powerful predictor of outcomes following AVR. And so on the back of this data, we designed a randomized controlled trial called Evolved. And the idea here is basically to see whether if we randomize patients who have asymptomatic severe aortic stenosis to, if we take patients who are asymptomatic with severe aortic stenosis and we find the patients who got scarring in their muscle, we're then going to randomize them to either having early surgery or the conventional approach of waiting for symptoms to develop. So this is testing whether early intervention in people with, I guess, objective evidence of left ventricular decompensation from the MRI leads to better outcomes. So the trial is finishing recruitment actually at the end of this month, so a couple of days' time, and then we're going to follow patients up, and probably the initial reports will come out at the beginning of 2024. So that'll be interesting to see whether we can improve outcomes by operating early in these patients, where we first see the scarring. Of course, there are other trials in this space, and people are very interested in the potential benefits of early valve replacement in aortic stenosis. This is the EASY-AS trial, which is an international multi-center study, a much bigger trial of nearly 3,000 patients that's ongoing at the moment in the UK, Australia, New Zealand. And here, this is a more pragmatic approach. Just anybody with severe aortic stenosis that's asymptomatic, you don't need the scarring on the MRI, gets randomized to early aortic valve replacement or conventional watchful waiting, looking for symptoms. So this will, and then of course there's studies in the US. There's the early TAVR trial. There's a study in Denmark, the DENAVA trial. So lots and lots of trials in this space, and including 2 recent randomized controlled trials that were small, but both showed a clear benefit to this idea of early aortic valve replacement. And all with this, I think, a similar underlying rationale, which is that you don't want this scarring to develop in the heart muscle and govern adverse outcomes down the line. So the final bit at the top is switching to patients with bioprosthetic valves. So this is after they've had their aortic valve replacement, and in the majority of patients now we're putting in bioprosthetic valves rather than mechanical valves. And of course with TAVI, the number of those patients is increasing a lot. But these patients, as I said before, we're not curing them completely of all forms of valve disease. We're kind of swapping one type of valve disease for another that still needs review and careful assessment. And that's because these valves can run into problems. And the 2 major problems are infection, endocarditis, and then degeneration of the valves. And the process that drives degeneration, the final common process, is calcification. But actually, these valves are harder to image than patients with native aortic valve disease, because you've got these metallic struts around the outside, and that causes problems both with echocardiography and also with CT imaging to a degree. So actually, this is one area where molecular imaging, I think, really has an established and useful clinical role. And the use of FDG PET as an assessment of inflammation, we're using this technique a lot to diagnose patients with prosthetic valve endocarditis. And you get images a bit like this, where you can see on the contrast CT clear evidence of a root abscess, and then very high signal in and around that abscess as a marker of prosthetic valve endocarditis. And again, this is for patients where the diagnosis is not established or clear from traditional echocardiographic assessments and blood cultures. And in those people with diagnostic uncertainty, then this form of PET imaging can certainly help and improve your diagnostic certainty of the disease. So, I mean, I think that's exciting as someone who's interested in PET imaging, where actually, molecular imaging and assessment of disease activity is already in clinical practice, already in clinical guidelines. And I think is encouraging, that we might be able to develop other methods where PET imaging and assessments of disease activity can certainly help. And so, the other disease that we might be able to help with is in the assessment of and detection of bioprosthetic valve degeneration. As I said before, the final common pathway of that is calcification of the valves. This is an example of a degenerate TAVI valve. And so in principle, the PET might be a sensitive marker, a marker of detecting valve degeneration early. And of course, with echo, we only really see the end stages of the disease process when the valve has fallen apart with a tear and regurgitation, or with severe narrowing. But here's an opportunity potentially to detect the disease process earlier. And so we applied very similar techniques to what we applied in native aortic valve stenosis to patients with bioprosthetic valves. And we started off with patients that we knew had degenerate valves who were either requiring redo TAVI or a redo surgical operation. And so when we did that, actually all the patients that we looked at had evidence of increased fluoride activity in their valves. But the underlying findings on the CT were slightly different. So in some patients, we had fluoride associated with overt calcification that we could see on the CT. But most of the time, we couldn't see much calcium on the CT, and instead we could just see the fluoride activity. And on occasions, that overlaid areas of pannus formation, as you can see in these two examples. Sometimes it overlaid areas of thrombus formation, this characteristic Holt appearance that you get on the CT angiogram. And sometimes it was really the only finding that we saw. We didn't see very much on the CT at all, but we saw increased PET activity. So these were patients who we already knew actually had degenerate valves. But we then went to study it in patients where we didn't know that they had any form of degeneration. These were people undergoing just clinical surveillance in the clinic where the echo was fine, the clinical features were fine. There were no concerns about degeneration. And we looked at 70 of those patients, and what was interesting is that in those patients, we could see increased fluoride activity in about 20%. And it was a very good predictor of what happened to the valve next. So these are 4 examples where, as I said, there was no clinical suspicion of valve degeneration in the routine surveillance. But when we did the PET CT scan, we saw very intense activity within the valve leaflets. And these patients all were needed redo surgery or TAVI after 2 years. So a very powerful predictor of the patients whose valves were going to fail. And if we looked across the whole cohort of 70 patients, there was a good relationship between the baseline PET and the subsequent changes in the hemodynamics of the valve. And it was the strongest predictor of subsequent valve degeneration or dysfunction, outperforming all the other kind of traditional methods. So, whilst I think the assessments of sodium fluoride PET in native aortic stenosis, I'm not sure they're going to find a clinical role, partly because CT is so good. I think actually in bioprosthetic valves, there may be a clinical role here because CT and echo, they struggle a bit in bioprosthetic valves, and the fluoride is really adding something different and something new, and the ability to detect degeneration of these valves early. A subsequent study, we looked at patients with TAVI valves this time. There was a couple of interesting observations. I mean, the first was that we could again detect increased fluoride activity in the valve leaflets as a very early marker of degeneration before we could see anything on the CT or the echo. And again, it was a strong predictor of a future valve degeneration. The other interesting thing was that when we looked at these TAVI valves, we also saw evidence of increased uptake in the calcium that had been squashed against the wall of the aorta, i.e. the native aortic valve calcium. So that's still lit up to a degree with our sodium fluoride tracer, which I think was interesting to us because that really suggests that this process in the valve, once established, is an active process. Calcification is active. So even after you've destroyed the valve and taken all the mechanical stresses away from it, still that calcification activity is ongoing and progresses. And again, when we looked at the TAVI valves, similar to the surgical valves, the sodium fluoride was a very strong predictor of what happened to the valves next, subsequent valve deterioration, and it was the best predictor of future valve dysfunction or deterioration. So I think that's 2 studies, both small single center studies from ourselves, that suggesting that sodium fluoride PET might be helpful in detecting early valve degeneration. And as more of these valves are going in and we're more interested in the follow-up of these patients, and potentially putting these valves into younger patients, then I think we do need a technique that can kind of pick up this disease early, so that we can try and, I guess, work out who we should follow up more closely, who we can leave to come back with less kind of close supervision, and potentially, if we can develop treatments, who we can start with anti-calcific therapies. The final observation was this: when we compared the patients with the SAVR valves versus the TAVR valves, and we looked at valves that were of a similar age, the fluoride activity was similar in the valves, as was the presence of abnormalities on CT and indeed on echo. So again, a small study, but I guess just pointing to what I think is coming out in the echo literature, that probably these valves are going to have similar durability. That doesn't seem to be a very high signal to early failure of the TAVI valves or a tendency to early degeneration. We'll keep an eye on that. It's obviously a very important question as we move forward, and will be best answered with large outcome echo studies. So I've talked quite a lot about PET tracers that have targeted inflammation and calcification, and these tracers have been around for a while, and they are potentially valuable. But I think what's most exciting to me, as someone who's interested in PET imaging in cardiovascular disease, is the emergence recently of two new tracers that now allow us to assess fibrosis activity and thrombus formation. And so between these four tracers, we've really got a lot of the pathology that drives cardiovascular disease covered, and now we can measure it in the heart valves as well as the rest of the cardiovascular system in real time to work out, what is the contribution of fibrosis activity to aortic stenosis. Here's an example of a patient that we've imaged recently with this tracer. Again, clear signal coming from the valve. And then also, what is the contribution of thrombosis? Particularly in biprosthetic valves, does the thrombus formation contribute to valve degeneration? Is it something that we should think about targeting when we see it, to not prevent necessarily strokes, but to prevent valve degeneration? I think a tracer that's really specific to thrombus formation and sensitive to it is going to be very helpful in teasing these questions apart. So that kind of brings me to the end of the bulk of my talk. I mean, I guess in conclusion, to come back to this slide, we are in an era of multimodality imaging. We've got lots of great scanners and cool toys at our disposal to help us understand heart valve disease better. And if we think about aortic stenosis, we can get very detailed information about the anatomy of the valve and also the heart myocardium, that I think will change potentially how we think about the disease, and means we don't only rely on valve hemodynamics in making decisions. We can look at valve function, and now we can look at disease activity. So is this going to be useful? Well, we need to do trials that that show that, and these are ongoing trials such as SALT-2, Evolved, EasyAS. Can they improve our understanding of the pathology? I think that's a definite yes, because these really give an insight into what's happening into our patients in real time and really allow us to understand things better. And hopefully that will soon translate into improved patient care and outcomes. So there's lots of people involved with this work along the way over the last 10 years. Some of them are up on this slide. And I'd like to just finish by thanking you for your attention, and welcome any questions and discussion. Thank you very much.
Marc, that was really wonderful. I think you did a great job of covering the aortic stenosis, kind of our current thinking, and what the direction of our thinking is going to in the future. And I think it's very exciting. And I think it always brings us back to everything we're doing, it seems like, is less invasive. And then in the end, prevention is where we're always heading with everything, which I think is phenomenal. And it's nice to see how you're using imaging to kind of help guide some of this discovery along the way. So I'm going to see if there's any questions from the audience. So for those of you that are tuned in, text DeBakey to 37607 if you have a question, or go to pollev.com and enter the keyword DeBakey with your question. And I know Mike here was writing down several questions. So I'm gonna turn it over to our cardiac surgeon, who whispered to me that this is a very fascinating talk. So I'm glad to hear our cardiac surgeons are finding this very interesting.
Yeah, Mark, a great talk, and there's a litany of questions that came up as listed. The latter thing you're talking about of imaging the active process calcium in the leaflets is very interesting, because one of the things we've worried about is that when we do TAVI, we leave these leaflets with this active process in place, and would that affect the TAVI valve? But it sounds like when you've compared it against surgery, it didn't seem to bleed over to the TAVI valve.
Yeah, not that we saw. I mean, we saw it there around the perimeter of the valve in all the patients pretty much, and so it's there and it's an active process. It didn't seem to translate in that smallish study into actual calcification or increased calcification activity in the leaflets. The rates of that were pretty similar between the SAVA and TAVA valves, but it's a pretty small study. I mean, I think that's a study that is crying out for a bigger cohort of patients. I was speaking to a group in the Netherlands, and actually they've just got funding to do that. A big cohort of patients with TAVA valves, imaging them at 5 years to see, what's the rate of valve degeneration at 5 years, and is it different SAVA versus TAVA and different TAVA models. So I think it's exciting in that area. But as you said, from the data we've got at the moment, it looks like the rates of fluoride activity in the leaflets themselves are pretty similar in the TAVA versus SAVA groups.
One of the things we're starting to see now, Mark, is more TAVR valve failures, just like all biologic valves, and taking out the TAVR valves. Once you take out the valve, the leaflets fall back into place. And when you cut those leaflets out, the calcium, it does not seem to be qualitatively or quantitatively the same as a native valve. It's softer. It seems like to me, it certainly looks like it's regressed in some ways. Do you think there's going to be anatomic changes in the calcium? Do you think this goes away with time? It certainly feels different.
Yeah, that's interesting. I've not heard that insight before. I mean, that would be great to look at that tissue under a microscope and see what's happening with it. I mean, certainly the signal is there from the fluoride suggesting that there's ongoing calcification activity, but there are different types of calcium, and perhaps the structure of the calcium is slightly different in that native or that residual native valve after it's been squashed against the aorta for a bit. I mean, I'd love to know what the pathology of that calcium looks like.
So I've got a question here from Sachin Goyal, who's one of our structural interventionalists, and his question is there any role for imaging to study regression of myocardial fibrosis after AVR? And I think he's particularly thinking about pharmacologic therapies such as ACE inhibitor, ARB, ARNIs. Yeah,
that's a great question. I mean, so the studies that we've done, I mean, I showed you the data about the replacement fibrosis. So, broadly you can categorize myocardial fibrosis into replacement fibrosis, which is irreversible scarring. And, that is irreversible. And, that is, you're stuck with that. The irreversible scarring you get whilst waiting for your valve replacement stays with you for the rest of your life. But the other form of fibrosis is interstitial diffuse fibrosis, and we can measure that with T1 mapping, and that does regress following aortic valve replacement. So there is a potential, and we can measure that. There's a couple of studies showing that T1 mapping can detect and measure that regression of the fibrosis. So potentially you could do a trial with some sort of drug intervention to see whether that accelerates the regression in the fibrosis compared to a placebo. I think that would be a very interesting study. And potentially you could also use the PET tracer for fibrosis activity to see whether you reduce fibroblast activation with the drug. Yeah, that would be good.
Yep. So let me ask you a question. So, I think you nicely showed how, a lot of these fancy imaging can help us not only from the standpoint of understanding the disease process, but also in potentially being able to manage patients, identifying when to trigger for surgery. And I think we're all excited to see some of this data coming out in the next few years. One of the questions I think that always comes up is all of this imaging is very expensive. And are we moving to an era where we're going to be doing kind of repeated high-end imaging on patients every year to try to figure out when the trigger is? Or could there be some biomarkers that you could use as a screening strategy to say, okay, this is now a patient you need to start to evaluate more seriously with imaging?
Yeah, that's a a crucial point. I mean, I don't think we should be doing MRI in everyone who's got severe AS, and because that's not cost effective. But actually, in Evolve, what we've done is that there is a screening step first based on troponin. So if your high sensitivity troponin is normal, then we say your heart muscle is normal. I mean, as you use high sensitivity troponin, you realize it goes up with pretty much everything. So if you have a truly normal troponin, you're pretty confident the heart muscle is okay. And so we only do the MRI in patients who have a high sensitivity troponin that's high. And that's good. That means that about a third to half of the patients don't need an MRI scan, and that actually when we do the MRI scan, we have a very high hit rate for fibrosis, about 70 or 80% in the trial at the moment. So I think that link between cheap, easy to perform, readily available serum biomarker, and then using that to target the patients with a kind of higher end imaging technique, is a really smart strategy, and one that I think we should use to guide, the use of these more powerful imaging assessments.
All right. So, Mark, one last question from me. One of the big issues we have right now is lifetime management, and everybody's moving to lower, younger patients, and trying to figure out who would do better with surgery and who would do better with TAVI. And we've come up with a number of anatomic things. If you remember in the Partner 3 trial, although everybody was approved locally, 34% were rejected at the national level. And in the Evolute trial I ran with Jeff, we rejected 14.8. So clearly we weren't treating everybody in low risk. Is there something beyond anatomy? Is there anything with more of the physiology that could help us separate who might go to surgery and who might go to TAVR? Where do you see imaging helping with that?
Yeah, I mean, that's the big question, isn't it? And there's even trials thinking about TAVR in patients with moderate aortic stenosis. I mean, I'm always a bit kind of cautious about that. I think one of the things that is one thing that's nice about that MRI technique is that it tells you when there's dysfunction in the heart muscle that's due to the valve disease. It's specific to the valve disease. So if you see that pattern of fibrosis in aortic stenosis, you kind of know the muscle is struggling, not because of ischemic heart disease, but because of the valve disease. And so I think that might be helpful, as we're starting to target earlier patients, identify who actually needs it or who we can wait a little bit. Because, as you said, the lifetime risk, if you put a valve in someone at 60 who doesn't need it, we're not necessarily doing them any favors by bringing that forward 5 years, because storing up trouble down the line with repeat procedures and complications. In answer to your questions about TAVR versus SAVR, I mean, I guess one of the things we worry about in younger patients is coronary access with TAVR, and so you can potentially model that with CT. Who are the patients that might be more likely to run into coronary access issues after their TAVR, and potentially put those patients more towards surgery. I mean, certainly, people with coronary disease, I think, we need to think carefully about surgery and, the longer term benefits that a bypass operation offers alongside the valve operation. So I think that's an area that imaging can help. I don't have a good answer exactly how at the moment, but we should think about it.
Good future research.
Great.
Yeah.
Absolutely. Well, that was an amazing overview, and we really appreciate. One, we want to congratulate you on all the great work that you've done, and we want to thank you for joining us today to share some of your work with us.
That's great. Thank you, Dip, and thanks, and thank you, Mike. Thanks for the invitation. A great pleasure to be there.
Thank you, Mark.
Bye-bye.